So hi everybody, I'm Dr. Crew. I think I know many of you from before. For those of you who don't know me, I'm currently chair of the Department of Physical Med and Rehab. I have a background in spinal cord injury medicine. I trained at the University of Washington in Seattle. Got a fellowship there after residency and dedicated management of spinal cord injury patients. I've been at Valley now is my 8th year. My focus is primarily on inpatient rehabilitation, acute consults of patients who are in the hospital who may need rehabilitation assistance and have spinal cord injury or brain injury or stroke, common three diagnoses that we see at Sacral Valley in rehab. And I want to introduce Rimma Katsovskaya. She is a wound and ostomy nurse, so she's been tremendously instrumental for our program for the patients who come through our rehab center. Not only on the inpatient side, a little bit on the outpatient side too. Not only does she help us in the rehab, it seems like a full-time job, she also runs an ostomy clinic for patients who have either had colostomy or had bowel diversion for other reasons. She is called all the time throughout the hospital to do the work with probably 3 or 4 people, and she manages to do it by herself, maybe with a student or another helper. She rounds with us on the rehab units twice a week. On Tuesdays and Fridays, we look at any pressure sores that develop in patients and try to prevent them from getting any worse, try to treat them to allow patients to start to mobilize out of bed. We have flap patients, a few every year. Spinal cord injury patients get flap surgery done. I'm going to touch on that for non-healing pressure ulcers, and Rimma kind of helps us manage those patients as well. So one of the things I'm going to touch on a couple times throughout the talk along with Rimma is that oftentimes pressure sore management and prevention is not just like a physician doing something that's magical, to be honest, because we don't have a lot of magic when it comes to this, but we have some ideas along with skilled therapists and skilled nurses, which Rimma is a leader in trying to make sure that our patients don't get pressure sores. For those who are beyond inpatient rehab in the community, like many of you here tonight and over the web, it becomes more of an education issue to ensure that patients and their caregivers understand why and when pressure sores may occur and try to prevent those situations from happening. So with that background, I'll get started. I don't have a ton of slides. I think we have 30 minutes, is that right? And then a Q&A? 40 minutes? And I think I have 40 slides. So we should be able to get through that, no issue. So the objectives today, and I'm kind of open to doing some informal discussion, so if there's questions, feel free to raise your hand, and I'll repeat the question for those that are over the web. So we're going to describe some risk factors, why is this such an issue for patients after spinal cord injury? Why are they at more risk than others to develop pressure sores? We're going to discuss some prevention and treatment strategies for pressure ulcers after spinal cord injury. And also, one of the reasons I really wanted to bring Rimma in, beyond the fact that she knows probably more than I do about this, is because she along with I have sort of been able to institute some new things with regard to pressure sore care at Santa Clara Valley. And so we are going to hear a little bit about what she's doing. I'm going to touch on the use of missed ultrasound and have Rimma expand on that. So pressure ulcers and spinal cord injury, how common is this problem? It's quite common. 80% or more, looking at most studies, will develop a pressure ulcer at some point after spinal cord injury. And I've kind of gone between the term pressure sore and pressure ulcer. We can get into the semantics of that, afterwards, but we're talking about wounds that develop because of too much pressure, typically over a bony prominence. So I think in most of my slides I'm using pressure ulcer. There's multiple predisposing risks, right? After spinal cord injury, most individuals have altered, if not absent, sensation and impaired strength below their level of injury. So there may be less feedback, obviously, with less sensation to the brain in terms of when you need to shift weight. I may be sitting at my computer at work, typing a note up or answering a call or, in the middle of a meeting, and, my body's going to tell me there's a little bit too much pressure over your right cheek. It's time to offload. You're starting to slouch. Your tailbone's giving you some feedback to automatically shift. And it's the kind of thing that able-bodied individuals are able to do sort of unconsciously and automatically, something that some of you sitting here right now will do several times while I'm talking without thinking about it. After spinal cord injury, you don't have that sort of automatic feedback loop intact. So the deep pressure sensation is usually impaired even after incomplete spinal cord injury. So we have patients who are very incompletely injured who have altered sensation and still at very high risk to develop pressure sores. And obviously if there's impaired mobility and impaired strength, shifting weight, even if you can feel that there's too much pressure, becomes problematic and challenging. So other risk factors is less elasticity. So there's actually studies done looking at the skin of persons after spinal cord injury, and the skin becomes less elastic. The collagen breakdown, the collagen being the key sort of matrix protein in the skin, becomes less elastic and more fibrous, and therefore more prone to breakdown and less stretchy over bony prominences. Increased healing forces due to muscle atrophy. Many able-bodied persons have cushy bottom to sit on because they have gluteus muscles that are there along with adipose tissue. A lot of that muscle mass can atrophy depending on the level of injury and the situation with regard to the spinal cord injury. And that loss of padding puts the bony prominences or butt bones more at opposition over the skin tissue that can break down with even an hour too much pressure, or even 15 minutes too much pressure sometimes on a very hard surface. And then there's slower reperfusion rate. There's also studies that have been done, cited, in the works below here in the PVA guidelines, as well as by Steve Kirschblum in his spinal cord injury text from 2011, showing that there's actually a slower reperfusion rate. So what that means is when you go to shift off of one butt bone onto another side, or to lean forward in your chair to do a pressure relief, the blood flow is going to be able to get to the tissues, but at a slower rate than it would have in an able-bodied person doing the same thing. So there's blood vessel changes, there's skin changes, and then obviously the change in sensation and strength creates this sort of setup for patients to have problems develop with pressure ulcers. And in case it's not sort of obvious, and I don't mention enough in the talk, the reason pressure ulcers form is there's a lack of blood flow to tissues between the skin and the bone. So pressure ulcers almost always form between that interface, whether it's behind the back of the head in someone who's had their head down, the butt in someone who's sat on a hard surface for too long, or the low back in someone who's laid on a gurney that's hard or a bed that's hard and not shifted their weight. The skin between the skin tissues, even going down to the fatty tissue below the skin surface, needs blood flow. So if the blood flow is cut off for too long, the cells will start to not be viable and start to either become deeply bruised and or necrotic and die off and create an ulcer. So I think I touched on some of this, right? If you think about all these sort of factors, the way this is depicting it as intrinsic and extrinsic factors. The intrinsic factors would be the things I kind of mentioned before after spinal cord injury, right? The sensory loss, the immobility, the elasticity changes, the blood vessel changes would be on that side. And then the extrinsic factors are the things on the left that, again, able-bodied persons are not so much of an issue because they can sort of account for it unconsciously by just shifting their weight or getting off of a situation that's clearly causing pain or creating friction at the skin surface. Something that I'm not going to talk a lot about today, which is probably obvious to all of you, and maybe some of you have even dealt with it, is the impact of heat in the predisposition persons after spinal cord injury have for having burn injuries. This is not an uncommon issue. I probably get 2 consults every other month with a spinal cord injury patient who's admitted to the hospital because they ended up with a burn. I would say at least 10 times a year I get called for that kind of a situation. And it's typically someone, was, dangling their feet in the hot tub, their wife went inside for a while, forgot to come back out, they didn't think anything of it, they pulled their feet out, and lo and behold, the bottom of their ski are scalded, and they need to have grafting surgery. This does happen. So obviously after spinal cord injury, if there's loss of sensation or altered sensation, become much more prone to getting burns. Talk more about moisture and friction and shear and pressure as the talk goes on. So even on this slide. So So pressure would be kind of what I was talking about before. If you can imagine laying on the floor and having your head in one position. Well, if you feel the back of your head, there's an occiput bone, the bone in all of us that sort of protrudes backwards, kind of like right here. And that's actually a very high-risk area in the hospital to develop a pressure sore. Because there may not be, the person may be altered, they may be in a coma, they may not be turning frequently, the bed might be too hard, they may have been on a journey to go down for a CT scan, a hard board underneath, and they forgot to take the hard board away in a quick enough manner, setting that person up to have breakdown over that area. So that would be like a pressure, a classic sort of too much pressure or too long a period of pressure resulting in spinal cord injury. So that's not the only thing. There's also friction. So friction is really just the opposition between skin and the surface. So that would be like directly like the back here, creating some forces between the skin and the bed itself as people are moving around in bed or are rolled in bed, or maybe they have the gurney put underneath them, and they roll, the sliding board, which we use a lot to transport patients from the hospital, is put underneath, and they roll, and then that hard surface can create some forces of friction between the two surfaces. So any surfaces that are in opposition moving against each other. And really what shear is if you can imagine this person's in a hospital bed, this can even happen in a wheelchair actually that reclines where reclining maybe goes back too far, and it ends up with the back of the wheelchair, the back of the bed here, sort of grabbing and clinging onto the back tissues, and the spine is going to want to move down and with the pelvis with gravity, so that downward force with a body that's sort of stuck or pushing against a bed can grab the superficial tissues while the bones of the spine and the pelvis are moving downwards. And what that creates is this deep sort of friction below the skin interface, and that can cause what we call a shear injury. So this is a very well understood phenomenon, a high risk phenomenon in the ICU after injury or after, even in chronic setting after a surgery, someone's in the ICU, their head may be up a little bit because they want to eat, they're not in the best hospital bed, they forget to put their head back down afterwards, there's shearing forces usually between 30 and 60 degrees of having the head elevated. So what we try to do is either have people sitting all the way up, right, in a nice, cushy, low air loss mattress in the hospital, sit all the way up to kind of take this out of it. So you sit all the way up, really you're just weight bearing through your butt bones, your ischial tuberosities, and your legs going down to your heels. But that friction and that shear kind of are taken away. So we always try to have patients either flat in bed or sitting up. So if they want to sit up properly, get them all the way up to 90, but avoid this sort of in-between position where you could slide off the chair. It's kind of like when you slouch in a chair and you feel like your butt's kind of falling forward and you need to scoot back. Or if you're in a really bad position in a wheelchair and you need to kind of move back, that's the kind of positions where shear can happen. So staging of pressure ulcers and pressure sores, I think Rimma is much more of an expert at than I am. The hospital actually gets fined by the state if pressure ulcers happen in our hospital, and Rimma has to be the one to kind of help with reporting our mistakes, which we don't have too many of, but they do happen.
Don't happen, very lucky.
Yeah, we're very lucky we don't have too many, but it does happen. So any pressure sore that develops that's deeper than a stage 2, we have to report to the state as sort of an outlying problem. The state comes and does an investigation. Hospital-acquired pressure ulcers are a big deal right now in hospital care throughout the United States because they're tied to reimbursement. They tend to prolong length of stays, and Medicare may or may not pay for the stay if something like this happens. So it's beyond just the obvious clinical reasons we don't want this to happen. There's ramifications for hospitals now if these do develop while someone's in a hospital setting. So stage 1 is like a non-blanchable red spot. So it's usually something that if it's caught early enough, this can go away with offloading the area a reddened heel. Maybe some of you have noticed one day, wow, maybe the shoes were too tight, or, you know, I didn't do enough of a pressure relief over my ischial tuberosity, over my buttocks, and there's a little redness there. It's not blanchable. If it's blanchable, it's not considered stage 1.
It's just sometimes it's dark skin, because it just changes a little bit dark color.
Yeah.
Sometimes it's not so red, but sometimes it's persistent. But if it's 1 minute, you can pregnancy persist. It means it's there. It's some damage already happened. You know, and we're going to be careful for one of some people like wearing socks, and socks is
I'll just put it.
Okay. If you're wearing socks and socks is that's okay, very tight, you also can have pressure also from that. You know, sometimes you have some like braces. You're wearing some braces. Braces can also cause pressure injury. Just very, it could be stage 1. It's very superficial, but it's kind of red flag. So the red flag, you need to be aware of that. There's something, even worth it happens further down, that it's tissue damage, and the more tissue damage, and very.
So it's usually something that can be reversed when it's caught at this initial stage 1. It's limited to kind of the superficial layers of the epidermis and maybe the outer layer of the dermis, but not down towards, you know, subcutaneous fat or muscle or bone. So that's the stage 1. Stage 2, there's actually an open area, right, and it's going beyond just the epidermis. It's going down into the dermal layer, not quite into subcutaneous fatty tissue or into muscle. Stage 3, there is full thickness dermal wound going down into typically the subcutaneous fat. And stage 4 is anything down into muscle or bone. So stage 4 ulcer is usually the kind of thing that puts someone in bed rest for weeks to months, and maybe even longer than that, or requires a flap surgery or another very aggressive treatment strategy to reverse. We'll talk about some, you know, things that we're implementing now. We'll talk about the use of vacuum-assisted closure wound vacs that can help with turning wounds, like even the stage 3s and stage 4s around sometimes. And on the right, sort of important to mention and timely is a deep tissue injury. We see these a fair amount on inpatient rehab. We, in fact, I've been reviewing a case of a 23-year-old with a new injury in Reading, who had a spinal infection and was home for a while. They slowly became paralyzed, and they went in on the ER. They weren't getting a lot of help. He was still walking. They thought this was just a soft tissue injury of his neck. He went home and fell asleep on the couch, and in the morning he couldn't move. He laid on his buttock for over 24 hours, not shifting at all, and he came in the hospital in Reading with a very deep purplish wound, which is essentially this, a deep tissue injury. And they found that he had a cervical spinal cord and an epidural abscess, a cervical spine infection, creating his paralysis. So he's come down to us for rehab, but right now we can't get him up in a wheelchair because he's got this very large deep tissue injury. And the thing with these is you don't know. You only can see here. You know that the skin is intact and there's a deep purplish dark spot over a bony area, and typically what that means is there can be significant involvement of the tissues all the way down to the bone. Sometimes, despite our best efforts at offloading this, all of this tissue is necrotic and will eventually die, and we'll slowly start to see this. So we're hoping, in this case, we got it early enough, he's offloading, and we'll be able to just turn the tissue around, and hopefully it's still viable with blood flow to it to heal. Rich, you had a question?
Yeah, would they be able to get that abscess in the cervical spine with a CT scan?
They probably would have with an MRI or a CT with contrast. I think the issue was he kept presenting with neck pain, and when young people present to the ER with neck pain, if their exam's normal, a lot of times they won't get a CT scan. He started to have other symptoms, and there were some reasons why, unfortunately, he got in a situation, but needless to say, he didn't know any better. He fell asleep on the couch, and his dad had to carry him off the couch and call the ambulance the next morning, but he was on one side for a long period of time, 12 to 24 hours. And, Rich asked whether or not they would have been able to detect his spinal infection if they got a CT scan? And the answer is yes, if they did it with contrast, although an MRI is a better test of choice for that, and I think that's what they ended up doing. Yeah.
You're describing detection that would occur in the bone. What if it was just tissue? What would it look like stage 1 or stage 2? So in fact, this is tomorrow, after 3 or 4, we're not talking bone yet.
Yeah.
Tissue, is there a way to detect that?
So you're talking about if there's no superficial skin breakdown and if it's dark, is there a way to tell if it goes down to muscle or down to bone? There is, if we got like a CT scan or an MRI, sometimes you can see tissue changes. Sometimes ultrasound can, but sometimes it doesn't. So there isn't a great reliable tool. We are starting to use ultrasound more in patients. We're sort of playing around with the idea of using it more in acute rehab or in a hospital when spinal cord patients have issues like this to see if we can detect some changes. But I don't think it's fully reliable right now the way it's set up. It's a good question. Unfortunately, we're usually left with, if this black area starts to become purple and then pink and then looks, normal colored and has capillary refill when we press against it, it's non-blanchable. That's a sign that the blood flow looks good, and we usually start to mobilize people. But that can take weeks sometimes, and unfortunately, it can take a long time. All right, so sites of pressure ulcers. I've alluded to this a little bit, but really anywhere if you look over your back, and I see this in patients who, again, are acute injuries, new in the hospital, or have been out several years and get hospitalized for pneumonia. We have a patient right now we're following who's ventilator dependent, who has several different spots of ulcers. Because he keeps coming in out of the hospital, he's been flat on his back quite a bit, ill, either in bed in the hospital or in bed at home, and he's starting to develop, heel sores, an elbow sore, and he's already got a tailbone sore. And before he went in the hospital with illness a couple months ago, his family saying, skin was fine. So even in good hands in nursing facilities that see a lot of patients with paralysis, and in our hospital, skin can start to have issues when people are stuck in bed rest consistently for whatever reason, post-operatively, medical illness, whatever it is. And then on their side, so we see patients, again, the number one area is definitely sacral for anyone that's getting a hospital-acquired pressure ulcer. A heel and occiput are quite common as well. Shoulder and elbow are less common, but we see it. And then think about any kind of bony areas in the body on your side too long, over the greater trochanter, the lateral hip bone, the outside of the shoulder, and the temporal bone, the side of the head. I haven't seen that one in quite a long time. We definitely see outside of the ankle wounds in the chronic population. That is not uncommon at all. And then think about some of you right now in the room in a wheelchair. If you don't have enough pressure relief over your buttocks, as I've talked about, or over the outside of your hip, if your wheelchair is too tight and pushing against you for whatever reason, maybe over the holidays you gained a little weight or whatever it is, and you're starting to get a little bit more pressure over the outside of your hip, that can be a pressure point that could create some pressure breakdown. In fact, that is a very common area outside of the hip for pressure wounds to develop in chronic spinal cord injury. And then the shoulder blade as well, heel and the foot are somewhat obviously mentioned there. So in acute spinal cord injury, and by acute I mean patients who have had injuries or new paralysis who are in an acute hospital or an inpatient rehab before they get out in the community. So 30 to 50% of spinal cord injury patients develop pressure sores within the first month. I mentioned 80% get one at some point, but almost half, maybe half, will get a pressure ulcer within the first month. And the occur bony promises, we've heard this several times. A variety of locations seen during inpatient rehab, I mentioned sacral, heels, and ischium. So occiput is number 4 on there. So almost 40% of all the sores that we see will be over the sacrum, which is the low back, including the tailbone. And the reason for that is, you can imagine people are flat on their back in bed. They may not be turned enough, and so they develop a lot of pressure over their low back. And in most patients, the amount of bone there and the tailbone is fairly close to the skin. So it becomes a fairly easy place to build up too much pressure and develop a pressure sore, particularly in hospitals where they may not have a turning protocol or a skin protocol after paralysis. The other sort of common thing after injuries, patients are transferred on a sliding board. They're on a rigid board. They haven't had surgery yet. Medics know there's a spinal cord injury. They're strapped down on a hard board. You can imagine that's going to create a lot of pressure. There's no cushioning there. So it's recognized that really within 15 to 20 minutes, you can start to get skin changes that may be irreversible on a hard surface between a soft tissue and a bony prominence. So it can happen quickly. That's why I think medics are very aware of this now and are trained to sort of try to turn patients. But nonetheless, we still see a lot of sacral pressure sores. And over 50% of these, over 50% of stage 3 and 4 ulcers are seen in inpatient rehab occur at the sacrum. So the worst ones, so most commonly at the sacrum, and what this thing is the worst one, the stage 2 and the stage 4, the ones that go down to muscle and bone are seen in this area. Yeah.
Where's the issue?
Issue is your butt bone.
Okay.
So, kind of a great model here, but so coccyx is your tailbone right in the middle, and the ischium is the butt bone, which everyone has two of. So I think if I go back, there's maybe a skeletal picture. So this is actually the butt bone.
Okay. So
I don't think this is projected. So yeah, this is the butt bone, and then the sacrum is this.
Understood. Thank you.
And the butt bone is here. So the sacrum is usually more of an issue for laying down, and the butt bone, the ischial tuberosity is usually more of a problem with it sitting too long.
Okay. Thank you.
Yeah. So sites of pressure ulcer formation and chronic spinal cord injury. As I mentioned before, it kind of changes a bit. Still sacrum is number one, but you see ischial is much more common, heels are much more common, and then the trocancers that we're talking about there, the greater trocancers, which are the lateral hip bones, I think I tried to mention before, which are right here. So the outsides of the hips, and usually that has to do with poor wheelchair fit. So it's typically why those form. It's usually not a laying down sore. It's usually more of these are typically more related to the wheelchair. These are typically, all three of these are actually typically more related to a poor wheelchair fit or a poor seating system or non-compliance or inability to do pressure release appropriately to get off of those bony prominences frequently. Over 25% of the stage 3 and 4 also seen after inpatient rehab still occur at the sacrum, but increasingly seen over the butt bone and the lateral hip bone, the ischium and the trochanter. So I guess I should stop here. Anybody in the audience have a weak stomach or not want to see wounds? I have a hard time not talking about pressure ulcers without showing examples, but if people want me to skip some of this, I can, but there may be some. Most people who live with spinal cord injury have to deal with tough, situations like bowel, bladder incontinence, but you've probably already seen them. So, everyone here okay with that?
Yes.
Yes? Confirmation? Okay. So, all right. So we talked about like pressure ulcers a little bit in terms of the stage 1, 2, 3, 4. So this is a patient who came into rehab from another hospital who, so there may be a little superficial breakdown and, we're doing some wound care and there's a catheter obviously in the bladder. That might actually be, no, I think that's a Foley. So this would be the top of the sacrum right here. The tailbone is probably right in here, and then you can see the cheeks on both sides. Any opposition on the webland to wounds? No one's saying, what are you doing? This is vulgar. Okay. So what do you guys see here? Well, you may have seen this in yourself or your caregiver maybe have noticed something like this home. What do you notice? Anyone want to take a shot at? Just kind of shouting out, what do you see here? Anybody? There's no wrong answer.
There's tissue degeneration.
Tissue degeneration, Rich said. There's definitely tissue damage, and there's tissue damage. I would say that is true. Anybody else? Next, it may not be obvious where the pressure point is. Probably because it's a broad area. This is low sacral. The tailbone is probably right in here. You see the tissue here is very, very deep purple. Everyone's doing pressure release in the audience. It's good. There's deep tissue damage here. It's deep purple to black. So actually, it's sort of a trick question. This is an unstageable wound because there's so much deep, dark tissue here. We have no idea how deep this wound goes. It could go all the way down the bone. So this is a tough wound to manage because we tend to have to be really patient and try to offload the area over time.
So how long would you know whether that is a real serious or?
That can take a while for us to know. The question was, how long would we know before this is serious or not? Some of these we're pleasantly surprised can turn around within 4 or 5 days to a week. Some of them, that picture doesn't change much. Maybe the size of it on the outside, the periphery of it starts to get better. The pink areas heal up. This is all going to heal. Everything from here out looks good. It's all going to heal. Really almost no matter what we do unless we leave them on their back. But the dark areas and the purple area, that could be all the way down the bone. Despite the best work, we might not be able to help. Are you guys okay? I'm not.
Yeah, he doesn't understand that.
Okay, good. Fair enough. So moving on to pressure ulcer prevention. So some basic things, when you're in bed, kind of try to turn at least every 2 hours in bed. If you have a nice mattress at home that's pressure relieving, low air loss mattress, really probably every 4 hours is plenty, because the mattress is very likely to not create any pressure points. So long as it's the right mattress for your situation. So typically in the community, every 4 hours is more than enough. But usually it's great to sleep 8 hours a night, so one time throughout the night, doing some turn. A lot of people will sleep kind of on their side with a pillow, and if they need caregiver help, just go in and remove the pillow at night, and they'll be on their back for the rest of the 4 hours, and then wake up in the morning and get moving. So patient and caregiver education. For those of you that don't know much about pressure sores, I think it's a really important thing to know about for persons after spinal cord injury because it can create a lot of hospitalizations, a lot of morbidity, potentially even mortality. Christopher Reeve passed away from a pressure ulcer that started, I believe, in his heel and developed a wound infection and led to ultimately him passing away. So this is not an uncommon problem that leads to a hospital stay, and as many of you know, when you get in the hospital, things can start to happen. You can get an infection from bugs that live, more in the hospital that are very resistant and hard to pick up and treat effectively. You can have other things go wrong when your routine is thrown off and you have a spinal cord injury. So it's a really important thing to know about and try to prevent. And even if they do form, just make sure that you're sort of in contact with with your team that can help you out. Now, we're always happy to be called, even if you haven't seen us for a while. And then I mentioned this before, avoid pressure, the shearing position. So some people say, well, I love my lazy boy recliner, it's really cushy, I want to sit in it. The problem with that is a lot of people sit halfway up. And if you sit halfway up, remember that shearing force is going to grab the skin while your spine is being pulled down by gravity, and it can result in a pressure sore. And then pressure reducing mattresses. Obviously, patients that are more obese, are higher risk. Patients with cervical injuries have more paralysis typically, so they're more at risk. Those without any motor sparing or sensory sparing are more at risk. African American race, in many studies we find that patients who are African American have a higher propensity for pressure ulcers. There's been a variety of things proposed about that, but no clear proven reason. Low blood pressure, behavioral issues. So obviously if someone's non-compliant, we unfortunately have a fair amount of patients who after spinal cord injury have a hard time being compliant. They throw their cushion on the floor, they don't like it, so they're sitting directly on a hard surface, or they're not turning it all in bed. A variety of things that set them up to have problems. So one thing we do have, I think I mentioned before, we have a custom seating and wheelchair clinic at Valley. I don't know if you guys use that, seeing Mary or Dow or Alyssa, our 3 OTs that are essentially dedicated to looking at custom seating, making sure people have the right setup and the right wheelchair and the right cushions.
Do you have to have a certain type of insurance to get there for that?
It's a good question. I realize I'm kind of going on. So you have to have, depending on your insurance, it will restrict how frequently you can get a new wheelchair. Typically with Medicare, you can get a new one every 5 to 7 years. So if you have,
Going into the hospital and get major.
yes. Problem sometimes arises, so there you can come in and get measured, vendors will come into work with you and the therapist on picking the right chair for you. There's typically some options that the patient can get involved in choosing between. But if you have a chair that you don't like anymore, you just got it last year, it can be really hard to get a new chair. Your cushion may be able to get changed and the wheelchair may be able to get modified, but getting a brand new chair, if it hasn't been a few years or there isn't a really good reason, can be hard. Vitamin D, I think I spoke to you guys a while ago. 80% of people after spinal cord injury are low in vitamin D. Vitamin D is an independent risk factor for pressure sore formation. So if you're not on vitamin D, it may help with your chances of getting a pressure sore. It's not going to negate your chances, but it is one risk factor. Patients who have very low vitamin D are at higher risk to get pressure ulcers. There's a variety of skin effects that vitamin D has that are protective. Patients who are darker skin have lower absorption of ultraviolet light from the sun and puts them at even higher risk to have low vitamin D and therefore have skin issues, which is probably one of the reasons we see more pressure ulcers in African American population. All right, cushions. It's important to have a good cushion. I can give you this more maybe in the Q&A if you guys have any questions. I found this on the internet. I'm from Nebraska, so I can say Rimma. This is sometimes we see patients who have like a folding wheelchair that you see like at an airport or, you know, randomly like a nursing home. These are not appropriate for people with paralysis, nor are scooters. They really don't take into account the pressure relieving that needs to happen. Now, these chairs are all very customized to folks who have spinal cord injury. Tilt in space for power is really critical. Lightweight chairs for paraplegic patients who have some dump in the chair, an angle that will allow easy pressure release. And then there's obviously quad rugby and paraplegia basketball chairs. Pressure mapping we do at our center. Management of pressure ulcers. I'm gonna hand this over to Rimma at this point, and let her talk for, maybe another 10 minutes or so on management. So obviously, I think we start to get Rimma into some considerations, and then dressings, and then flaps, and ultrasound. So I'll hand it over to Rimma. Here you go.
Okay.
I can advance the slide.
Okay.
Okay.
What's that? The piece is
7:45.
Oh, so we got it. Okay.
Oh, okay.
So
All right.
I can advance this.
Okay. What are we doing? Okay.
I'll just clip it on.
Perfect.
Clip it on. Maybe I can hold this.
I can click it. All right. Let's click it. Okay. I can't click it.
I just go this way.
That's okay. That's okay.
That's good. Yeah.
I think you can hear me. Management, it's very important, and it's very important to prevent something from happening. It's more difficult to heal something. I will tell you then it's very challenging. And particularly if you had injury and you want to have more independence and moving around and be in wheelchair. What we're looking, yes.
Speak a little louder.
Loud, okay, sure.
This microphone is for the internet.
Okay, I will. Thank you. What we're looking at lots of things. We're assessing wound, the location, very important. Where is the wound? We're looking at size. We're looking on the length of wound, on the width of wound, and we're looking on the depth, if you can see the depth. We're also looking if anything, like you saw picture, it's not, I will tell you, it's not the gross picture in the world. That picture was actually, for person, it's, we see more difficult patients, but we're looking if anything, like tunneling. Tunnel, it means it's going underneath of the tissue, the tissue damage. What can we do? What can be done? And of course, if you have redness around the wound, because sometimes it could be wound infection. Wound itself can be infected, and actually pressure injury can, right now it's called even pressure injury, not pressure sore, pressure also right now is just new, it's called pressure injury. It can create actually overwhelming sepsis, and sometimes it's smell very bad, because odor is also important, because what bacteria is there, what we're looking for. Of course, like I mentioned, pressure and shearing forces, it's very important. In some patients are in bed, unfortunately, because when they're in rehab, they're supposed to be 3 hours to do therapy, and sometimes we cannot get them up because of the pressure also. And when we're looking on a wound, what we're looking, we need to clean that wound, right? Because if you have anything, like fecal material in a wound, sometimes feces there. If you have necrotic tissue, when it's not viable tissue, we need to clean. The most important, clean. There are different modalities how we can clean. And of course, we need to create clean wound environment and appropriate dressings. There are a variety of dressings, and we will talk a little bit about some dressings. And we have some people, we have lifts right now. If you see, we have some special lifts in the rooms. We have actually in some areas we have lifts on the ceiling, which is very helpful. Sometimes actually lifts can cause pressure injury as well. It's kind of interesting stuff. So we have special mobility. This is all. I want to tell you something. One of the important parts, and I'm preaching to people, make sure that you have good nutrition. If you're eating well and you have really good quality of skin, you have elastic skin, always make sure that your feet really have not dry skin, scaly skin, because elasticity of skin is very important. It's one of the things. It's called tissue tolerance, because if tissue is not, we cannot pull it, right? Tissue cannot tolerate it. Tissue can break down very easily. That is a big issue. You want to talk? Okay.
Yeah, there you go.
Why we talk about not only wet to dry dressing, probably majority of you maybe know about wet to dry dressing, but we're still using sometimes wet to dry when it's needed. But we're cleaning. We're using gas, right? We're using gas, and it could be any gas that we just got 2x2. It could be 4x4, big 4x4, don't bring, and we need to clean it. Normal selling, it's not normal environment for cells to grow. This is why we're using normal selling. But we have different variety of dressings. Some of them I brought. They're not fun right now of Duoderm just to cover it, and I will tell you why. Because we had actually, it's called Sentinel event for us. This is Duoderm hydrocolloid, but there are a variety of hydrocolloids. This is pretty thick one, and this is thin one. It's kind of much thinner. What's that? Name of the product, it's called hydrocolloid. Its name is Duoderm. And there are different sizes. You have 4x4 size. Majority of ours is 4x4. It's in inches, or if it's centimeters, it's 10x10. 10x10 centimeters.
You also said you're not putting that on.
We're not putting right now so much in the wound. We had very interesting, like I said, sentinel event. Somebody put Duoderm because before it was very common, and patient was incontinent, and next person came, clean incontinence and full dressing, but full dressing together with skin. And all the skin, this side of skin came out. Okay? Just think about that, and so it's need to be very, very careful. When we're removing any dressings, we need to be very careful. Because some people, they do like this.
No wound where the dressing has been on way too long.
No, actually, that was not long, but what happened, the tissue, the person who had person actually had predisposition. The patient had suspected deep tissue injury. The tissue was purple, was very weak. Sometimes you can see that tissue is weak. It's not normal skin, not normal standard skin. It's already was weak skin. If you're putting something on a weak skin, and you can peel it off very easily. It needs to be very, very, very careful. We have hydrogel. Hydrogel is, I don't have Aquasolve, actually, unfortunately, was taken from market, but we got it a little bit new one. We have extra soap, and if you want, I can pass around if you want to see it. Do you want to see it? Okay. Yeah, thank you so much. Yeah. And actually it's usually for dry wound, but also not very moist wound. And it's good material because we can use it. We can put on a wound, and it can stay for 3 days, and we can see it. What's happening? It's actually, it's clear, you will see it, it's clear. And we have good results. We can go on superficial wounds, not very deep wounds, and we cover. This is called extra soap hydrocolloid dressing. And we have different sizes. You're supposed to have different sizes, but we have this size, and it's working for us. I cannot tell that it works all the time perfectly, but quite often it does work, okay? In a superficial wound, like stage 2. I will probably stage 3, if it's a deeper wound, I probably will use something else. But it's available also in gel. I didn't bring gel with me, but I brought it iron dressing, yeah.
So this is not to be stuck right on the skin?
You
put gauze first and then put on top of it?
No, you can use this as a secondary dressing. Yeah, you can use it as a secondary dressing. You can put it directly on the skin.
Okay, but if there's tissue that's questionable, so when you remove this, it doesn't keep the skin with it, you put gauze to protect, and then this is a secondary? Or
oftentimes you use it on both sides of the dress.
We sometimes using this for taping this actually for the tape. For the tape, actually, I will be very careful. Anything if you put on a skin, then it needs to be when you're taking off dressing. It needs to be very careful. I do. It's called push and pull. I push skin down all the time, and I gently pull it out. This is what I found. It's very kind of beneficial for us. Because
the way to dissolve the adhesive or something like olive oil, so it's going to be less heat, you better take it off.
Why do you need to, you can use alcohol, but I will say don't use it, because you never know how your skin will react on something.
Okay.
You know? Stickiness is good on one hand, but when you remove it, be very careful. We have foam dressings. We have a variety of foam dressings. There are adhesive dressings. There are adhesive. There are not non-adhesive. But foam dressing look like this. This is the brand name Alluvium. I'm not advertising for any companies. Okay. Just want to tell you, but it's cushion, and we cover it actually. Some wounds we just use it could be directly to the skin, or sometimes it could be like secondary dressing. It means we put gauze, like you mentioned gauze. Sometimes we're using gauze with something, and then we put it foam dressing. Also, if you have some problems with braces or something, we start to use. This is also another kind of foam. This is Mythorex, white foam. And the good part, I can cut it any shape I need it, and it's a little bit sticky. If you look, if you will take this part is sticky. And it can stay, you can put in the skin directly under the brace. You can cut it shape what you need. Like people who have neck collars, for example, and it's neck collar might cause, and they have bones protruded here, we can use this. And it's work as a protection. Oops. It's called Mythorex. And it's also foam. It's just a different kind of foam. Okay, we have
You need a prescription for this, or can you buy it?
You can buy it. You can buy it, but if you buy it, you're paying from your pocket, right? But you can use a prescription, particularly if you have a wound and you have prescription. Insurance company cover if you have wound. They cover for this. But this is available. There are different kinds of foam, but you're looking at adhesive, a little bit adhesion outside, and it's very helpful to distribute. And alginate, I didn't actually I bring today alginate. It's not alginate, but it's I brought some. It's Acrosol AG. It's very absorptive. If you have, we're putting this in a wound when it's like infected wound, draining wound, the pattern inside, we're putting this material dry. If you want, you can put a little bit of water and see how it will absorb. It's very interesting to see that. Okay, and we have a variety of gases, of course. You want to talk about flap?
I'm going to hold off on flap surgery for now. We'll get there maybe in the Q&A. I want to cover this for sure before we end.
Yeah, this is Dr. Crew and I were probably very proud because we got it to the Clara Medical Center that needs therapy. It took us only 4 years.
It took us, three years to get through a lot of speed bumps to get ultrasound therapy approved for wound care.
But it's available right now, and we start to use for patients who have pressure injuries, pressure ulcers, who have like deep tissue injury. We start to use for those, and we start to use for stage 3 and 4. And I will tell you, we have very, very promising results. It's non-contact ultrasound. Non-contact. It's a low-frequency ultrasound, and it's energy. It creates like an energy, it's like waves. You cannot see it, you cannot feel it, but it's coming through the normal saline. And what it does, it really stimulates wound bed, like it penetrates inside the wound deeper or through the skin. If it's still like a deep tissue injury, skin is still intact. Skin is damaged, but it's intact. It penetrates inside like 3 millimeters. It's improved blood flow. And actually, after treatment, it's improved blood flow. And when you have improvement of blood flow, and it removes like sometimes necrotic tissue as well, you create better healing potentials. And you will see right now how what we have and how this is how it looks like. This is just like normal swelling going through here. You cannot feel it. Here we have physically ultrasound, which is like rotating and penetrating to the skin. But it's non-contact. It means the ultrasound itself doesn't touch skin. It just goes through. And it's individual kits. It's for a patient. For each patient, it's very individual. And the clinic to have sterility is much between patients. It's very important to have cleanliness. This is very interesting. This is our patient, and Dr. Crew was first one who saw this patient. And what happened to you wanted to tell us, what did we do? I got a call. I will tell you, it was very interesting. I got a call, and nurses called me and said, Rimma, you need to see this right away. I said, what's going on? They just got admission.
Down.
Okay. And they just got patient, and it's a she. And it's a... And it's a stage 4, but what is the stage 4? I said, what is the stage 10? Because it was the stage 4, I said, okay. But Dr. Crew already came to this patient. On report, we got it, the patient had skin intact. Okay, skin intact.
She came from the hospital, the skin was still intact. She's African American, and they had a dresser. They had a dresser and some tape for this.
And when we look, this was wound, and I'm not exaggerating. I think we had approximately 13 centimeters. It's like this, 13 centimeters, like this. And Dr. Chris started the debridement at that side right away.
The first thing we do that to do is this is like a deep scab. And it doesn't allow tissue below to sort of start to fill in and fill the void. So you have to take all this dead tissue off. So I had just used forceps. The patient had no sensation there, so I used forceps and very slowly with the scalpel to take off a few different layers. When it was all dead tissue, there was no blood flow to it, and I got down the blood, and then we started to use other treatments.
We were doing mist therapy, ultrasound, and we were doing, I think we were doing central ointment and rheumatic debrider as well. It's probably, you'll probably see something like this. It's by prescription. It's only by, you use that. Yeah, yeah.
Tissue that needs to bleed out on stage 2.
We got pizza coming in, so we're gonna.
Oh, okay.
So this is the one before.
This is became better. Okay.
And the wound's starting to clean up. You can see that it's maybe a little hard to appreciate, but this is all tissue. And so now we are starting to see some of it that we had start to heal in. There's a rim of viable tissue coming.
Yeah, just red tissue, and then all the blood. This is, unfortunately, it's not the greatest picture, but
more of the wound is starting to come out. So this is within like 2 weeks, and just a little bit of debris on the scalp with a lot of the missed ultrasound. This is another.
It's also it was unfortunately a patient came to us with this wound.
Another African American patient.
Yeah, very young, 18 years old, gunshot wound, and became paralyzed C2 from neck. It means then dependent. And then he came to us. This is what we saw. How it look like. It's what you see here. This is necrotic tissue. We didn't know how deep this wound will be. It was probably, as I recall, it probably was like 7 centimeters by 5 centimeters wound. And we were just like, okay, what we're going to see next, because this is just surface. Then, 2 weeks later, I started to do mist therapy, and we were doing debridement at the same time. Really, like bedside debridement to clean it. Seeing how this wound look like much better from here to improvement. Red is good. Red
is bad, and white is not great. It's fibrinous. So there's a lot more pink and red beefy tissue. That's good. That's exciting. 2 more weeks.
2 more weeks. If you look at what is here, Dr. Cruz said, what is that? What do you put here? Okay. I want to tell you that the location of the wound was very low. It's just all bone, but it was very close to the perirectal area, very close. And in order, patients didn't have rectal tube. Patients had bowel programs. And we start to use mist therapy, and we start to use negative pressure wound therapy, VAC, if you have VAC dressing, it's machine, which negative pressure, it's pulling fluid out, it's really machine. But in order to have good seal, because it's negative pressure, we need to have good seal, particularly in this area, because just below. I use ostomy paste. If anybody ever have, or you have people who have stomachs, colostomy, ileostomy, we have ostomy paste. And I use paste just around the wound.
Like a glue almost.
Yeah. To seal. And he went, this patient, we were able to transfer this patient for later healing. We don't have the best pictures, but then they really had very good granulation tissue.
Yeah, this is looking much more superficial, very healthy.
And it's decreased.
I have some other slides. I, of course, like usual, thought I had more time or talked too slowly.
This is very important.
So this is something that comes up a lot. So there's a little vignette here, but you see a lot of this, both in the acute and chronic phases after spinal injury. So what is this? You want to take a crack at it?
Elbow. Did you get the mic?
Oh, yeah. So we're almost done. It's a dark heel, yeah. So yeah, it's a calcaneus, it's the heel bone. So yeah, it's calcaneus, the heel bone. So what would you do here? What would be reasonable to do? If, you know, you woke up and had this, or you're the caregiver and you see this in the morning. A waffle boot's like a soft sort of inflatable cushion that the heel can sit on. A duoderm is that one that Rimma said if you put on and peel off too quickly, if it's too adherent, may take skin away. Debridement in the OR, this is not something that's bad enough to go to the operating room yet. Prafo boots, do you know what a Prafo boot is? So that, black or blue boot that usually has offloading of the heel and a very soft, cushiony surface. So the right answer would be a Prafo boot. A waffle boot still allows pressure, and B and C are not the right option. So basically the idea here is you don't want to have any more pressure. And so putting tennis shoes back on that day is a bad idea. That's going to create maybe this getting worse. It's the same picture as before. So what treatment is most appropriate here? Wound vac, wet to dry, bed rest, low air loss mattress, every 2-hour turns, gentle debridement of open areas, collagenase dressings. This is the right answer. It's usually the longest answer. So you asked the question, Rich, what do you do with those big sticky pads? A lot of times we'll put them on the skin that's intact on the sides, and then put a dressing in between that we change, and then we use tape. You can actually still see leftover tape here. That tapes the dress in between, so we're not putting too much tape directly on the skin. So that's where we use the duoderms a lot. And there's the summary slide. Thanks. We're moving to that new building next year. Hopefully. No, it's happening. It's going to happen. Yeah. Sorry, that took a little longer. I know pizza's here. Do you guys have any questions? Any questions online? One question here. Yeah.
So is the new room without home?
Yeah.
At which point we should go and administer the ones to basically admit that without phase 2 or phase 3?
So the question for those of you out there who may be listening, at what point should you go to the emergency room with the wound? Is the basic question. And I would say, Rimma also wants to chime in, but I would say that going to the emergency room may not be the best idea. Unless you're sick, you have fevers, you're feeling unwell, you're vomiting, have fever, a real change in your normal status. Just a pressure sore alone, unless you can't get to a clinic to see a rehab doctor or you can't get them on the phone, I think that going to urgent care or the ER may put you in a gurney or a bed that may make the wound worse. A lot of times they'll call me. I fielded a lot of calls over the years from Valley ER saying, hey, there's a patient here, an old patient who's from spinal cord injury, who is coming in, they're dysreflexic, they look like they have a pressure sore, can you come see them? We'll go see people in the ER for this sort of thing. But I think the better option would be, once you start to notice this, as Rimma was preaching prevention and early detection, call the clinic, we can try to get you in. We also have a wound clinic, for those of you that don't know, and usually they're very short waiting periods. It's run by physical therapy. Dr. Shrem has some involved in that clinic. And they're actually now open, I believe, 7 days a week. We have a full clinic every Saturday and Monday through Friday. Rimma doesn't work in that clinic, but we work along with them. They also have ultrasound. They have everything that you see here. The therapists actually do sharp debridement with scalpels there when they need to. So a better option would be to try to get an urgent referral into the wound clinic rather than going to ER and potentially be on a hard surface or something that could make things worse. But you should go to ER, again, if you're sick, feeling unwell, plus the wound or something like that. But just for the beginning of a wound, I wouldn't go to the ER. Anything to add, Rimma?
I think absolutely right. Prevention. If you see something and if it starts to grow bigger, or just odor or something, you just see that you cannot manage. Because if it's stage 1, stage 2, and it still can stop. But when it's going deeper, then it's bad. Because we see some patients who have wounds for 5-10 years. And it's catastrophic because wounds, when it's closed and people coming back to us, back and forth. It's like, you just catch on time. If people need to check skin check at least every day to be sure, then everything okay.
Any other questions? Anything online, Robert? They're all asleep and bored.
Any advice from the running in the remote area, specifically,
Good question. Nick asked, what are the options or what would you recommend for someone who lives in a remote area who may not have access to us or to another physician that has spinal cord injury experience? There's two things. One, we have a telemedicine program, and a lot of times we're able to use iPad technology or even mobile phone technology to do a telemedicine visit, or to simply call us. A lot can be accomplished through calling. We can get photos transmitted securely without releasing any protected health information. And the telemedicine program allows real-time FaceTime to even look at wounds. So Dr. Sherman has done this a lot. I've done this several times with patients as well. This was one of the reasons for the creation of the telemedicine program, was to allow us to remote in patients who are far away to look at skin issues. But I would also say that if you can't get a hold of anyone, typically most urgent cares or ERs have somebody who can make a recommendation. The problem is with large ERs like ours down the street, they can be overrunning with folks. If you're in a remote area, a lot of times the local ER urgent care doesn't have as much business, and you may be able to be seen sooner. So I think try to get in touch with a physician as soon as possible, or a therapist that you know that has spinal cord injury experience to try to get some help.
Good question, Ryan. Is allogel useful to nourish the affected area of stage 1 sore?
The question was, is aloe, like ALOE, is allogel an effective strategy for stage 1 sores?
Yeah, nourish the affected area of stage 1 sore.
So aloe helps with hydration. It's great in terms of helping with like a blister or a burn that may need hydration. There's a variety of things you can do, but aloe, I would say, wouldn't hurt. Now, for a stage 1 pressure sore, it's usually not a burn issue. It's or even typically not even just a friction issue. It's usually a too much pressure issue. So if it's an area that's dark red and not blanchable, aloe is probably not going to help that much. If it's an area that's blistering and burned, aloe could help, but I would say, again, in that situation, really needs to be evaluated, because sometimes what may look like to be a superficial wound or burn in someone that doesn't have feeling can be much worse.
I would tend to agree that the pressure issue is oxygenation. So any pressure problems, uploading the calorie you have to take, whether it be by a superior function pushing, theoretically, if you do that, you probably would have a problem. Sometimes there's cushion issues and then catheter issues. They're semi-muscular unless they have caregivers in place. I'm talking about high injuries.
Yes.
The more areas that you need caregivers or some really excellent equipment. And that's kind of a marginal discussion too. There's various things on
I agree with all of that. To summarize for the folks on the web, comment was essentially there's a lot of different equipment out there and options to help offload pressure-bearing areas and bony prominences, particularly for patients who have high-level cervical injuries who may need specialized seating systems and a cushion that works for them. Yeah, some cushions, Roho cushions or air cell cushions are really good for people that have a lot of support in their wheelchair, but for someone who has a minimal wheelchair, maybe a pair of, but without a lot of core muscles, it can be a problem because essentially the person becomes unstable in it. For someone in a power chair with essentially a rigid back that's a high back and has lateral support in the wheelchair, you can get away with doing a very minimal cushion. And I'm saying all this with an expert in the room, with Rod sitting here. He's one of our OTs. He could probably elaborate much more on
I've been in the chair for 36 years and have used a Roho cushion 35 of those years, and then I started having problems, and that has a story of its own. But one of the areas that I wasn't aware of, and it took decades to get it, was if my footrests were a little bit high in relation to the cushion, it shifted a lot of the weight back to the ischiums or tailbone. And so you just share the load. It's really important to make sure your footrests are in a good position. Sometimes you'll change the cushion, it'll be a lower cushion, and all of a sudden that's like raising your knees or your footrest if you don't make adjustments there. And those were some of the things I had to learn the hard way.
I'm going to hand it over to Rod just in case he wants to say any more about seating systems or cushions.
Yeah, I think all great points, and going along the lines of the Roho cushion and everything, great point about the footrests being adjusted properly. But I think with Roho cushions, air cushions in general, they're a great seating system. However, one thing that's really overlooked a lot of times is using it properly. So it has to be inflated correctly, otherwise it kind of defeats the purpose. So if it is overinflated, someone's not paying attention to how they're actually setting it up, and then in turn it's probably creating more pressure on the ischial tuberosities, and it's defeating the purpose of what that seating system was generally designed for. But I definitely like what Dr. Koo was mentioning, where the Roho air cushions with stability and everything like that on a power chair, you can definitely get away with it based on the systems that you can place on there, give you more stability versus someone who's a para in a manual chair. A lot of times they do prefer the gel cushion, they prefer that stability, but there's always going to be those pros and cons, as far as the weight of the cushion, overall lightness of the chair and everything like that. But I think the biggest thing is using that equipment properly, because they are pretty complex. They can be very custom, but the biggest thing is being able to use it properly. And with an air cushion, it is a little more complex than just throwing a gel cushion on there.
All right. Maybe one more question, and then the pizza's probably getting cold. So, question, I'll let you speak.
I just wanted to know, how do you determine whether the cushion is correctly working effectively, especially a Roho cushion? Do you have at Valley Medical, like I've heard of?
We actually have a handout where Roho has.
I'll go to the pressure map slide too.
Okay. So there is with Roho cushions, and it depends on which cushion it actually is, but they do include step-by-step instructions with illustrations. If you ask, 5 different therapists, they probably have their own methods of doing it, but there are handouts, and honestly, I would just go on the Roho website, figure out which cushion it is, and they generally do have the step-by-step tutorials of how to properly inflate the cushion.
And then sometimes to decide whether or not cushion is off-loading or is not. I don't want to comment on pressure.
Yeah, so if there's ever any question about whether or not the pressure distribution is compromised in whatever seating cushion you're using, then we'll definitely use the pressure map to see if there is uneven pressure distribution on it. And another big thing is, and I think it's great for patients to see, is when you're doing a weight shift, how effective is that weight shift? So you can see in real time the pressure being unloaded when you're doing that weight shift.
That's good. All right. Thanks, everybody. I'll stick around. Thanks, Bob.